I'll talk about a subject that is kind of undermined by the gravity of the injuries that we see in the country, but it's something that we face from time to time and we have to deal with. No disclosures. This will skip. So blunt carotid and vertebral artery injury, they're rare but potentially devastating, 25% mortality and 50% neurological deficits. The mechanism of injury, usually motor vehicle accidents or falls, assaults or suicide attempts, or that the patient does not recall what happened to them. The arteries can be twisted or stretched or impinged by bones like this one. It's a recent case that the patient presented with a stroke actually, and we found this very long styloid process impinging in the carotid artery. So these are the mechanisms that we see, but the ones that we fear the most are these in the skull base because they're most commonly missed. 80% initially they have no deficits, but later on they come to show themselves within 12 to 75 hours. And if missed for more than 48 hours, they cause 80% mortality. So what the patient can report, if they can report anything, a sharp ear pain or expanding hematoma or cervical bruit in a patient who is younger than 50, if you look for it, or lateralizing deficits that doesn't make sense with the CT scan that you see. I'm not going to ask, but I will show this as an abnormality. Could look like this, but the worst that we deal with is this, and we have to be very suspicious of these patients and look at them. Now, to screen or not to screen, CTA is a very good tool, and you can see a double lumen, you can see irregularity in the wall, you can see absent vessels like this one in the foramen transversarium fracture, or extravasation. If you see it, you know that the patient is in bad shape. Treatments we're going to look at with either heparin or warfarin or antiplatelet therapy, surgery or interventional as needed. So this is a case that actually referred to me by Dr. Al-Na'mi at, I think, the first week he arrived in Abha, where he did not have the interventional procedure at the time set up. And the patient came to us. He's a 28-year-old who earlier, by 11 months, had a car accident with skull base fractures and significant epistaxis. It took him 12 days to come to us, and that's something that I'll discuss later on. So it showed this very large aneurysm into the sphenoid sinus, explaining the bleeding. We told him the option of stent or coil or clip through a skull base approach, and we went for coiling to keep it simple for the patient, and that was successful, alhamdulillah, and the patient left the hospital a few days later. Another patient who is a 28-year-old, newlywed with sharp pain into her ear. Somebody looked at her and knew that she was newlywed and thought of cervical spine, but then looked at the cervical spine, it was normal, but a good radiologist picked some irregularity in the vertebral artery, and that it was a dissection, and the patient was treated with aspirin for 3 months and recovered. This is a typical patient that we see in head injury, and you see this one, GCS of 8, somebody hit by a car. You think this is traumatic subarachnoid hemorrhage, but we look at the posterior fossa, you know something is wrong. We did the CTA. The CTA went to an angiogram, and the angiogram showed the left vertebral dissection. Took him to surgery to evacuate the hematoma, but also added the far lateral approach to occlude the vertebral, but we found a very bad looking vertebral artery, 14 millimeter tube with very rugged walls, so surgery was abandoned and went for therapeutic deconstruction of the posterior circulation. So initially, the treatment is, according to the severity of the dissection, you can either offer observation or heparinization. Most of the patients will be treated up to this level. Few patients will require stenting or surgery. If it's a complete occlusion, then we have to give them, if it's a complete occlusion, you give them lifelong antiplatelets for protection of the other vessels. If it's a transection, there is a big debate with the vascular surgeons and neurosurgeons as to what to do, but an iatrogenic occlusion will not make the patient any worse. Divine intervention, I call it, because this is a patient who, 64-year-old diabetic hypertensive, slipped in the stairs and fell on her buttocks and then felt severe pain in her neck, radiating to her left ear. Given NSAIDs, and she came 2 days later with amaurosis fugax. That was strange, but not entirely, because the daughter was there and she insisted to get an MRI. Do you see the problem? The entire left internal carotid artery is missing, actually. So she's intact, she's neurologically intact, has no deficits. And when we look at her compensation mechanism is in fact the persistent trigeminal artery. So I did tell her, you must have done something really good in your life and God protected you. So that's, she's on aspirin for the rest of her life for that, but she's doing very well. And we need that from time to time, not to go crazy, I think. This is the most important slide in my talk because all of these patients come from our colleagues who I listed them here, mostly in the Eastern Province, and you see the name of Dr. Bassem Sheikh because when he had renovation in the angiogram in his place, he called me and referred cases for interventional procedures. And you see on the other side, he is my first collaborator because he was my first mentor in neurosurgery as a resident. And Dr. Annami, who we communicate a lot about patients, and Dr. Kurdi, who you saw earlier, and Dr. Moulani, who's my partner in Eastern Province, Dr. Makhlafi in the Western region, and yeah.
And time is over.
Yeah, and Orzdan Yamani. Now, we move from egocentric practice to patient-centered practice, and this is one of the cornerstones of what makes the SANS a great place to be. Thank you very much.